Are going to be talking about social prescribing. When initially asked to contribute to the AHP celebrations, I remembered a leaflet I picked up at my doctor's surgery about this wonderful scheme, which rather than immediately reaching for medication, helps to heal people individually and holistically by ticking all levels on Maslow's pyramid. As we know, there is a strong link between mental and physical health. As allied health professionals, we help to facilitate the ability to complete each level by promoting painless mobility, speech, nutrition to tackle pathology, confidence, motivation, etc., etc. Social prescribing brings everything we facilitate together and drives people towards self-actualization. It's an amazing service and one we can promote within our capacity as AHPs. Kerry is a link worker and Anna a manager for the local area coordination team. I'm very grateful to Kerry and Anna to agree to let us know all about it. So over to you.
Thank you, Sarah. And it's very nice to meet everybody. And thank you for sharing your time and helping us to help you celebrate all of the good things that you do on a daily basis. When Sarah first asked us if we would deliver what we do at this presentation with regard to Maslow, we both felt that whilst we're not experts in Maslow's hierarchy, it was definitely a good way that we could look and explore the link worker and the local area coordination role, and to show how we support people to move in line with their own motivation and support level. We will be using YouTube to explore Maslow, and so hope the technology works. It's nice to meet everybody. Thank you. If we could have the next slide, please. Thank you. So, social prescribing, what is it? It's often called social prescribing, it could be a community referral, and it's done in many ways, but in its essence, it's a way that non-medical options can be offered to people that will have a positive impact on their mental and physical health, because it's done in a way that is meaningful to them. It's an opportunity for people to have time and for finding links that will enable them to share experiences with people, have a voice, and be moved between professional sectors and their community. So we don't see people as their condition, we see them just as a person. From a Maslow perspective, we'd be looking to sort of move people through the levels in a way that makes sense to them, much like you do in your role, but we would be helping people to move through the different levels. And social prescribing is listed as one of the 10 high impact actions from NHS England in the forward view. So that's how we fit within the long-term model. So hopefully we'll be around for a long time yet. Thank you. Next slide. So link workers. We are a health initiative. We're centrally funded, but we all sit in slightly different ways, but we align with the primary care network structure, and GP practices will have access to at least one link worker. Some practices have access to two. Most link workers came into post just before lockdown, so some were in post before, but most during the lockdown period. So their work has been predominantly telephone based until coming up now, really, whereby we are starting to get out and about in the community a little bit more, but we're all aligned with GP practices.
And from a local area coordination perspective, we sit within public health at Leicestershire County Council, and we form a key part of the local prevention strategy. Local area coordination is a national, international programme actually, so we work in accordance with the principles outlined by the local area coordination network to make sure that we're working in the way that makes local area coordination unique. We've been around since 2015, so we're well established in the county, and our team members are based in sort of targeted specific communities where we know that there are varying demands, and that some preventative support can be useful in preventing onward movement into other services. Next slide, please.
So we'll now go into the clip for Maslow.
Hello and welcome to today's lesson where we're looking at Maslow's hierarchy of needs. Before we jump in and look at the theory, first a little background. Abraham Harold Maslow was an American psychologist who first introduced his hierarchy of needs in a paper entitled A Theory of Human Motivation. Now, the theory says that as humans, our actions are motivated by our desire to meet specific needs. Now, Maslow focused in particular on the needs of employees in the workplace, and his theory identified 5 types of needs that need to be fulfilled in order for you to reach your full potential. Now, the 5 needs come in a particular order. Only when one set of needs is satisfied will you think about meeting the next set of needs in the hierarchy. Let's jump in and take a look at the model. From the bottom to the top, Maslow's 5 levels of needs are physiological needs, safety needs, social needs, self-esteem needs, and self-actualization needs. Now, the pyramid represents a hierarchy, and what this means is that only when a lower level of needs has been fully met would you then be motivated by the opportunity to meet the next level of your needs. Now, the key to understanding Maslow's hierarchy of needs is to realize that your needs are continually changing. So what motivated you 5 years ago or even last month may not motivate you today. Now, there are a couple of ways the model can be broken down at a high level that you can see on the right and left-hand side of the pyramid here. Now, the first is by breaking the model down into deficiency needs and growth needs. Deficiency needs, sometimes called D needs, are needs that motivate people when they are unmet. Now, the longer deficiency needs go unmet, the stronger the desire to fulfill that need will become. Therefore, satisfying these needs is vital to avoid unpleasant feelings or even death in the case of physiological needs. So, for example, the longer you go without water, the more crucial getting water will become to you. In fact, if you're dying of thirst, you're not going to be interested in, for example, improving your French. Now, the top level of the hierarchy concerns growth needs. Now, confusingly, these are commonly known as B needs, which means being needs. You can also break the model down into basic needs, psychological needs, and self-fulfillment needs. According to the model, you begin by being motivated to meet your lowest level of needs, and only once you've done this do you move on to being motivated by the next level of needs, and this process continues until you reach the very top level, self-actualization. Now, although the theory was originally proposed as a very rigid hierarchy, Maslow later modified it so that the progression up the hierarchy doesn't have to be quite so strict, and that levels can overlap to some extent. Now, that makes sense because for some people, achieving status, level 4, might be more important than, for example, attaining love, which is level 3. So let's examine each of the levels in a little bit more detail. So first we have the bottom level, which is physiological needs. And these are basic physical needs that you must meet for you to live. They are vital to your survival. These needs include food to eat, water to drink, air to breathe, shelter to protect you from the elements, warmth to avoid freezing, and sleep to refresh you. Now note that Maslow included sex within this category as a basic physical need because reproduction is vital to the survival of the human species. The second level is safety needs. And once you've met your physiological needs, the next needs that you'll look to satisfy are these safety needs. We all want to feel safe and secure. So these needs include being free from war, natural disasters, and violence. In the workplace, these needs include things like job security, a safe working environment, having access to grievance procedures, saving some money each month, and knowing you have health insurance should you become ill. Now, physiological needs and safety needs combined are often referred to as your basic needs. The third level is social needs. At this level, you'll have a desire to develop your interpersonal relationships. You want to feel as though you belong to a group. Now, these needs include intimacy, friendship, and family. And according to Maslow, at this level, you'll feel this need to belong to one or more groups. Now, that could be a family group, a workplace group, or even a social group. And belonging to a group is commonly called affiliating. And that simply means you attach yourself to the group or to a club. Feeling that people love you, that they care about you, and that you belong to a group can help you avoid issues such as loneliness, anxiety, and depression. Next, we have esteem needs or self-esteem needs. Now, these needs are your ego needs and your status needs. At this level, you'll be motivated by getting recognition from others, achieving a high status, respect, and feeling important. Now, in a nutshell, you want to feel like you're making a contribution to the world and that others recognize this contribution. Now, according to Maslow, there are actually two sets of esteem needs, lower esteem and higher esteem. Lower esteem is simply the need for respect from others, whereas higher esteem is self-respect. Now, note that if you meet your lower esteem needs, but your higher esteem needs are unmet, then it can be common to suffer from a condition known as imposter syndrome. Now, the top level is your self-actualization needs or your fulfillment needs. And this is the drive to become the best that you can be. It's about achieving your full potential as a human being. You can think of the first four levels of the hierarchy as being a set of levels you must master in order to enable you to reach this top level. Now, because we are each unique, at this final level, each of us will pick something individual to us at which we want to excel. Now, it could be the desire to be the best parent. It could be a desire to be the best athlete you can be. It could be a desire to create the most beautiful art, but it is unique to you and it's something that's going to motivate you and you alone. Now, there are a couple of variations to Maslow's hierarchy of needs that you should be aware of. In 1970, Maslow upgraded his original 5-level model on 2 occasions. Now, first to include cognitive and aesthetic needs, and later to include transcendence needs. So the first update to the model you can see in this diagram. And you can see that this update includes more growth needs while keeping the deficiency needs the same. Now, let's talk about cognitive needs. So once you fulfilled your deficiency needs, Maslow believed that you would then be motivated by expanding your knowledge. Cognitive needs reflect our need to discover, to experiment, and learn how the world around us works to expand our understanding. This is a crucial step towards self-actualization as it involves opening your mind up and exploring new ideas based on evidence. Next, we go up a level to aesthetic needs. Now, this can mean appreciating beautiful things in your life, but it can also mean achieving balance. So, for example, walks in nature can lead you to feeling refreshed, Likewise, experiencing music can also leave us feeling rejuvenated. When we meet our aesthetic needs, we feel intimately connected to the beauty of the world around us. So the second update Maslow made again kept deficiency needs the same and added one final level to growth needs called transcendence. Now, transcendence is the very peak of the pyramid and refers to having our spiritual needs met. We become motivated by values that transcend beyond ourselves. Now, there are several advantages and disadvantages associated with Maslow's hierarchy of needs. So first, in terms of advantages, then the model is easy to understand and apply at a basic level. It expresses the human desire to achieve and to have more and more over time. It's a holistic approach to motivation. Maslow's model helps us understand that an employee or a person won't be motivated to perform, even if promised a great reward when they're tired, cold, and hungry. Now, in terms of disadvantages, then there's no way to test Maslow's concept of self-actualization empirically. It doesn't take account of cultural differences. So, for example, the need to feel part of a team is going to be higher in certain countries, such as China, than it is in other countries, such as the US. Also, each person will value each need in different ways. So esteem needs can be essential to you, but your peer may play a higher value on safety needs. So, for example, Van Gogh self-actualized through art, but lived in poverty for his whole lifetime. This calls into question the need to move up the hierarchy one step at a time. Now, in reality, we typically don't focus on meeting one need at a time. Instead, we seek to satisfy many needs at the same time. So, in summary, Maslow's hierarchy of needs shows what motivates us. What motivates us is constantly changing. This means that what motivated you last year will probably not motivate you this year or today. Now, Maslow's original hierarchy was broken into 5 levels. A person starts at the bottom of the hierarchy, and only once needs at that level are met will they be motivated by trying to meet needs at the next level. Now, broadly speaking, the model can be broken down into 2 categories of needs. The first, deficiency needs, are things which motivate us when they're not present, and second, growth needs, which motivate you to grow and become the best you can be. So that's it for this lesson. Really hope you enjoyed it, and I look forward to speaking to you again soon.
Thank you for that. I hope that gave you a little bit of an insight and probably a video that's well worth going back to from time to time. I think what we wanted to do next was to talk about what this means from our perspective. So if we could go to the next slide, please. I think one of the big points I'd like to draw out of the video is that, as was kind of said, we will meet people along the way that are at all sorts of different stages of this pyramid. We may meet people who are looking for self-actualization when, you know, they have some physiological needs that, you know, would do with being met. And I suppose the important thing from our perspective is that we work with people with what they're wanting to do at the point that they're wanting to do it. But we wanted to kind of give you a bit of insight through the levels and the type of work that might mean for us. So if I start off at the bottom with the physiological needs, again, as it said in the video, this is the real basic stuff. And whilst neither of us are kind of a crisis service, we do meet people and encounter people that live in situations where any one of these things can be compromised or difficult for people. So some of the work that we'll do is things like linking people to food banks, support services, and other things to help some of those more immediate needs be met, so that we can then go on and do work around some of the other bits of the pyramid. And I'll go to Kerry for the next one.
Hiya. So from a safety and security perspective, it could be that we are there to have that up-to-date and well-informed information so that we can link people in to those local support networks, to link them in to employment support if that's what it is they're looking for. So, but again, helping people to feel safe and secure and able to achieve those things that will make a difference for them. But I think the importance is it's about that local and well-informed, up-to-date choices that can help them to make that next step to feeling secure.
And for love and belonging, again, this is all around our relationships, and very much understanding that people have different ideas of what a good relationship looks like and how much they have. Some of the work that we would do would be about linking people in with others, but specifically others that are close to them in terms of their community or that have similar interests, life experience and goals, and that maybe where there aren't naturally places for them to do that, we can look at establishing that with people.
So moving up to the self-esteem elements, people that are now feeling that actually their housing is secure, they've got employment if that is what they look for, or they feel safe in their environment, and they've got that connection, and so are able to think of what they'd like to do next in gaining a sense of achievement, in gaining in confidence. And just by linking in, so we both as a link worker and as a local area coordinator have really good links with adult learning or with informal learning, formal learning opportunities, again with others that are experienced within the field of supporting people to connect with other people that will make a difference because they have similar interests, but take them towards something they would like to achieve, whether that's formally, informally, whether that is because they're joining the local knitting group and so they're learning new skills, whatever's meaningful to that person. It might be that they're joining a local allotment group, so again, or that they have opportunities to feel that they're sharing.
And yeah, at the very top there, the self-actualization, I think that really is almost a bit of a full circle moment for some of the work that we do. And then when we've worked alongside people to move up the pyramid, quite often people end up in a position where they're wanting to give back, or you know, support other people, and whether that's formally through volunteering or informally, whether it's being the person that they would have hoped to have been around, whether that's offering support to other people that are going through similar situations than them, whether that's because at one point they needed a food bank and now they want to help make that food bank sustainable for other people. You know, it's about looking at ways to keep people engaged and to give back for some support they've had as well.
And I think a little bit but people may well go full circle too, and so it might be that they get to that self-actualization space, but something else happens and then need a little bit more support. And so again, it isn't that we get people to one space and that's it. A little bit like your roles, I'm sure we can revisit different elements with people, but the hope would be that they have developed support networks in that time that would reduce that as a possibility.
Yeah, and sometimes they come to us when they're right at the top already and they're going, I don't need help, I want to help others maybe, or do something else in that respect.
Thank you.
Next slide, please.
And this is possibly a slide that you've seen before, but I think the theme of triangles is quite a good one. And so social prescribing link worker role would sit very much at the bottom of this triangle. So it is available to anybody within the population that feels they're in a set of circumstances that has left them needing a little bit of support in order to connect. And sometimes we do work with people that have a number of physical conditions and need a little bit of support to negotiate those, but predominantly we would look to people with experience to support that. But again, we see the person as a person, and so if it is that they would like to achieve something that they feel is achievable outside of their health conditions, then we would look to who best we know to support them to achieve that. But the link worker role sits very much within the personalised care model. Thank you.
Slide. And again, a definite theme here. We've got another triangle. I appreciate this might be quite difficult for you to see, so I'll do my best to explain it to you. But this is public health prevention triangle, and it follows a similar theme. But in it, I just wanted to show the approach and some of the other things that are probably available across the county within the public health offer. Similar to on the previous slide, with, as Kerry said, with the social prescribers, we sit at tier 0 at the bottom. So there's local area coordination and some other work in there around time banking. Again, our offer is whole population. Our offer is targeted within specific communities, but it's about having timely conversations with a person when they might need it most. And, you know, a variety of needs could be addressed there, and you know, it's about building capacity with people and places and trying to make that as open-ended for people as possible. In tier 1, where we've got First Contact Plus, and we've also got programme delivery and the health improvement teams, this is really about connecting people to a variety of pathways to meet a need, where if not, then there might be a decline in health or a decline in some of those other conditions. We might see people dropping down and getting to a point where they're needing much more intervention from people. Tier 2 for us, this is where we start getting more specific. So things like Quick Ready Stop Smoking and weight management. It's when we've got a specific service for a specific need, which has a specific impact on people's health and well-being. And that they're trying to address that. So they're providing more intensive support to help people reduce their smoking or reduce their weight. And right up at the top, tier 3, this is the real specialist targeted support, where appropriate skill level is really needed around intervention. And an example of that from public health may be around drug and alcohol misuse and detoxing. And I think again that the model with all of these and what we're trying to show with the triangles, it by investing at the bottom and by putting as much in at the bottom to get to as many people as possible at the right opportunities, we hopefully prevent people from going up both of those triangles and needing more intensive care, needing to have more of an input where they perhaps could lose their self-reliance and become more dependent on others and other services, and at points as well, you know, real costly support. And I think from our perspective, while that is a factor, it's about people maintaining their independence. You know, I think if we think of ourselves in these sorts of situations, you would want to do as much for yourself as possible, wouldn't you, and keep your independence in that sense. Next slide, please.
So just a little bit more then about what social prescribing link workers do. We look to support non-clinical interventions as part of the wider GP offer, and we see people in a holistic way, regardless of any condition that they may or may not have. It's what does that mean for them and what would they like to achieve. We take the time to explore what matters and then help them to together make an action plan based on what it is they've said are their priorities. We look to what's already worked well so that we can encourage them to become more resilient and have greater self-care, which can then lead to that sustainable change that, like Anna said, hopefully we can, by doing that, mean that we're stopping them getting further up the ladder and needing that more intensive support. So we also look, because people are feeling better more naturally, that hopefully the prescribing of medicines will be reduced, but we definitely hope that people will be contacting GP practices or other health professionals less for things that maybe aren't treatable through those clinical interventions. Obviously, we want to encourage people when that clinical expert is needed, that is exactly who they see. But those longer conversations about the non-clinical interventions are the ones that we will have. We can also hope that, because not all GPs live in the areas for the people that they serve, we can highlight what is important in that local community, and sort of look at what matters. From what is unique about us, we are linked to the GP practices. We have direct link to medical practitioners, so whilst we're not clinical, we do record on people's health records. And so if there are sometimes people can get confused if there are other professionals involved, so sometimes we can link in with those other professionals as well, that people might, so that we can reduce that just a little bit. We do have guidelines that suggest we should have between 6 and 12 contacts per person. And so the hope is within that time, we will have helped somebody to develop a plan and look to who we know that can support those sustainable changes within the local community. So if we can go back one slide, please, to the local area coordination slide. That's perfect. Thank you.
Thank you. And so likewise, just to give you a bit of a summary of what the local area coordination team do. So we work with adults, so sort of 18 plus, but we do some work around families, I suppose the adults of families, across a whole population over a very wide range of issues. And we do that in accordance with 10 powerful principles. I won't bore you with all of those, but I think the important thing there to say is there's a lot of crossover with what we've already discussed. There's principles in there about the importance of relationships, about lifelong learning, about using the gifts and assets that we have to give back to our communities. The main foundation of our conversation is, what does a good life look like, and how can we make this a reality, by walking alongside people so that change is sustainable and transformative for the person. A lot of our work is underpinned by those principles of not doing for, but supporting people and enabling them to be able to do things themselves. A lot of the conversation I have with my team is, if you were to remove us from the situation, this has got to be sustainable and ongoing for the person or the group or the community that's there. We connect people to their communities and help them use their natural assets to improve them. Some communities have got lots going on, some not so much, and we look at what's important to people, and we help them to think about how they might go about setting something up and how they might be as inclusive as possible for the people that live there. As with Kerry, our work is person-led, and we believe that individuals are the experts when it comes to their lives, and so they guide us on what we do. And I think, again, linking it back to Maslow, you know, we may be in someone's home and thinking there's a real basic physiological need here, that, you know, you kind of think that that's what somebody will want to talk about, but it might not be. It might be something to do with feeling more connected to their community, and that's where we would then focus with them. We work with communities to help them be resilient, inclusive, and meet the needs of the people that live there. And a really good example for that for me is around the pandemic. We definitely saw in communities where there was access to local area coordination that the response was a bit easier, that we could see that there were already things in place that people in communities could connect to, and that sharing of information was really something that was a lot easier to do. In terms of what's unique about us, as I said, we work in specific targeted communities, which is identified from a whole host of data sets. Sometimes it's about rural isolation. You know, we work in some small villages in Melton. Sometimes it's around higher levels of deprivation. Sometimes it's around the makeup of the population. Sometimes it's about just the demand that things like health and social care are felt from it. So we aren't everywhere, unfortunately, but we are in the best placed areas in terms of where need is. The team are based in those communities, so we use libraries, we use community centres, parish council offices, so we're there and we're accessible. So in terms of making the most of walking down the street and bumping into somebody and having those timely conversations, we're best placed to be able to do that. We have an open door policy in terms of introductions from residents and professionals, and a lot of what we do is try to aim to reduce the barriers to support. So we'll have a conversation with anybody, and if we can signpost or do some longer term work with them, then we will. And there aren't lots of referral forms, etc. And I think we're able to provide a responsive and flexible way of connecting with people. And, you know, we're in a very privileged position where we're not time bound. So some people will have one conversation with them and that will spark and give them everything that they need. For other people, we may be working with them for several months. But again, the aim of the game is sustainable transformation for people. But that is one of the reasons that we're not everywhere, because to allow us to work in that way, we have to work towards sort of population sizes, which means that we can be that intensive with people. We'll go to the next slide.
Thank you. So both roles, the link worker role and the local area coordination role, are very person-centred. As such, we look to meeting people where they are in a place that makes sense to them. And if we think about inequalities in health, I think that we are able to take the time to be where people feel comfortable. So home visits are often offered to people, or it might be that there's a space that they feel safe in that we can meet them in. And in that way, we're not reliant on having to be within a GP practice or a formal setting. Having said that, if that is where the person feels comfortable and confident and safe, that is exactly where we will meet them. So a lot of those initial conversations will be about exploring how we can actually make that time the most positive. It might be that meeting somebody new is very difficult for that person, or it might be that mobility is difficult. They might be anxious. I think reflecting on what we've all been through COVID, like Anna said, people are feeling quite different now, aren't they? And so actually getting out in the first place might be difficult. And so again, we follow a lot of the PPE regulations, but we can now go and meet people in their homes. It might be that people need a number of visits before they actually feel they would be able to go out. So it might be that they know what it is they'd like to achieve, but taking those first steps is particularly difficult. And so there isn't any rush for us to actually go and do that. We can take our time. In the first instance, if that person needs a company in, then we can definitely offer to do that, if that's what's going to help them to actually make that first step. For some people, giving them the information would be sufficient. And so it is very much about having that relationship with that person, gathering that understanding. It might be that we could arrange to actually meet them at the location. It might be that we offer them a prompt. But whatever it is that would break down barriers to that person going into whatever it is they've established they would like to achieve in that first instance. We go at the person's pace, and they are definitely in the driving seat of the journey. It does mean that we offer that real time. It might be that we link in with the group that they're going to go to. We have an understanding of the different things so that we can set the scene and really make those first steps as positive as they possibly can be. Again, with the hope that if it's a positive experience, it's going to be something that can become sustainable, so that the confidence and skills can develop to enable that to continue without the support. Next one, please.
So what does a good introduction look like? So we work in general quite holistically with a lot of different issues and people in different situations. It's very challenging, I think, to give a bit of a list of we do this, we don't do this, and a lot of it's kind of all part of the conversation that we have about that person and what they need. So one of the biggest things for us is just clear consent from the person about the, you know, the fact that the conversation's taking place, that we might call them, and you know, and that they need to understand that they will have to be able to action some of the change with their support. You know, our aim is to facilitate sustainable change and work alongside them. And I suppose maybe to kind of maybe have a bit of a health term, I suppose that when we look at someone with an injury of like reablement potential, you know, somebody's got to be able to undertake some of the work and do that with support, but to be able to make that change for themselves. We need to understand just generally why the person's being introduced and what is understood that they need help with. As we've made clear, I think we may end up working on other issues, and because of the longer relationship that we might have, just some of the different conversations, the different settings, sometimes that can spark other issues as well. If possible, I suppose the person's view on what they want and need, you know, and we can further tease that out with them. Any communication issues that a person has, you know, it's really helpful to make sure that we have the best start with people possible. Any risk issues, I think generally speaking, and I think this is accurate for you as well, Kerry, we have workers that go out as individuals. They look after specific areas, specific GP practices, and whilst we have robust lone working policies and stuff, it is important that we understand if there's a need to buddy up or to do joint visits, or if it's appropriate to meet in specific areas. And another, I suppose, important one for us is just any other professional involvement. We really don't want to duplicate things. We don't want to cause confusion for a person. Sometimes we're not best placed to do a piece of work there and then. Sometimes we may need to have a conversation with the other professionals, and it may be a case of once something else has been done, then we can pick up, because it can get quite confusing for the person, and likewise I suppose it can get quite confusing for the professionals involved when we've got many people trying to do many things as well. Next slide, please.
Thank you. And so, like Anna said, I think that the social prescribing role and the local area coordination role are available to and appropriate for all people at some point. But those that might not be appropriate for either of the roles just yet might be those that don't have any capacity to consent or be able to action any of their goals on their own, because like we said, the aim and the intention is to support somebody to develop resilience, to have that support network, and to achieve, to be able to then transfer that into other areas of their life. So somebody that's in a mental health crisis, for example, needs the support of the mental health teams. That doesn't mean to say that once that crisis is averted and has been supported appropriately, there wouldn't be areas that we as link workers or as local area coordinators could then support with. But at that moment of crisis, it isn't right that people come to us. Also, sometimes we will get introductions where somebody is asking for help for somebody else. Again, we do really need the consent of the person that wants to make those changes. It's important that we're working with people, not for people. So if it is that somebody's asking for help for somebody else, we need to say to that person, we're willing to help you, but the other person would need to approach us themselves and have that understanding that it's a mutual relationship where there are expectations that that person does some things and takes some account and has accountability for their actions themselves. Thank you. Next slide, please.
So we just wanted to cover really succinctly how to access us. So in terms of local area coordination, as I said, we do try to reduce as many barriers as possible. So there's two things really. You can make contact directly with the local area coordinator for that area to discuss the introduction and just some of the nuance around it, and to make sure that it is appropriate. I think one thing that's worth mentioning here as well is because we work in different communities facilities, there are often different things available for people. So where it might be quite easy to meet one need somewhere, another team member, that might be more of a challenge for them. So again, the landscape can look a bit different depending where people are. We do have quite a complicated political landscape in terms of our borough district councils and things like that, and they all have a slightly different approach to things. But likewise, our contact details are fully shareable with the public. Again, the team will field any phone calls or emails that they get, and really what we'll do is have a bit of a conversation with you, discuss the best approach, and then we'll make contact with that individual and just take it from there, really. And I will share all of the team's contact details with you to be circulated as well.
And from a social prescribing link worker perspective, because the money is centrally given but locally applied, it's slightly different in different areas. So some link workers are employed through GP federations, some are employed through local councils, but that's why contact through the GP practice is universal. And it doesn't have to be a GP that the person speaks to, it could be any member of the practice staff, because a lot of GPs are still encouraging people to actually go, aren't they? Which is why we don't want to say that people have to see a GP, but they can be accessed through their GP practice. There can be options to self-refer into some link workers, and so some practices will have information on their websites or notice boards. But again, because of COVID and the restrictions, some GP practices currently have notice boards, some less so. There are leaflets that, again, I will share so that the information is on the leaflet that can explain a little bit more as well to people what the role is and how it can be accessed. The aim is to accept external introductions and broaden it out. But again, this is different, slightly different for different areas. But the going through the GP practice is universal for all link workers. Next one, please.
Yeah, so it brings us sort of to the end, but the question portion of the session, if anybody's got anything they want to ask us.
Well, I just wanted to say thank you so much for coming to talk to us. That was really interesting, and I know for sure there's a lot of people that I see who would benefit from your services. And as a podiatrist, hopefully we could improve their mobility to get to all these events as well. So thank you for that. I know this session is being recorded, so we will be able to reach a lot more people than are here today. So thank you again for that. And Carrie and Anna, you were talking about a leaflet as well that would be available online that we could perhaps put out to people as well.
Yeah.
We're interested. So
yeah,
thank you very much. That's great. So are there any more questions at all from anybody?
I can see Deanne, you've got a hand up.
Can we have the slides?
Yes, I believe so.
Yeah, is that okay? I'd like to just read through that again, because I think you do a great job, and it's very similar to what I do, as you know, Kerry, because we've had many conversations on the street, haven't we, over the years? But with regard to referring for link or local area coordinator within my team, is there a specific referral form, or would we? I know the doctors are universal and there are different ways. I've just heard what you're saying, but I just wondered if there was a referral form that we could fill in to refer people to you that we feel are in that situation where they're not in crisis, they are ready and they are able to make a plan. Because, as you know, Kerry, our service is very time limited, and you have a little bit more time to be able to spend with the person, putting that plan together and helping them to, to access things that they want to access. And the other thing is, during COVID, it's been really difficult to find things to help people with. And like you were saying, it's also quite difficult because of the nature of COVID, and some people are you know, just very cautious about going out. I popped to a community centre today in Burbage just to see what was going on. One coffee morning a week is as much as they can muster at the moment.
Yeah.
Because and nobody's doing anything. It's like nobody wants to be involved. So that's really sad. A whole community centre sitting there with one coffee morning a week. So
and I think I agree, and I think it's something that we've all encountered a little bit. But as things emerge, it might be that actually how we can support you with regard to that is by information sharing.
yeah.
And so if it would be, Maria, that you wanted us to come to a team meeting specific to look at how we could best do that, please feel free to give me a ring or drop me an email, and I'm sure that between us we
can
facilitate that. That won't be a problem.
If you could come and do one of our learning breakfasts and share today, that would be great. Thank you.
Absolutely. And with regard to, so we don't have a referral form. I think because like we said, we do need that person to be able to do that currently. But again, I'm always happy for people to give me a ring, and we can just look at the best way that can happen. But there isn't.
Is there a kind of an introductory form that I could share with that person, explain what you do, and you know, and introduce you in that way?
The leaflets that we will share. So after this, we'll both Anna will send a link for the local area coordination one. I'll send a link for the social prescribing one. Within Hinckley and Bosworth, which is the area that you're in, we have got a personalised link worker leaflet, so I can send that on to you as well. And so yes, that by all means can be shared with the person to sort of look at that. I think it's actually quite a good way of doing that, because they can then see from the beginning there is an expectation on them to identify what they'd like to achieve and have that understanding that we'll achieve that together.
And I think referral forms and stuff, they can be a bit of a challenge for us, because I think if somebody puts a need down and then you think that need is being met, but then with the person it's not something particularly of interest to them, I think you can just kind of get a bit sort of cross wires, I think, and people have an expectation of how something's particularly working. And I suppose the difficulty with yours that probably drives people bonkers, in a world of black and white, we are so firmly in the grey, it can be very hard to record some of that. And I think when you're looking at and hopefully as you kind of build relationships with the team, having those lines of communication and being, if you're wanting to have some feedback about something, I think the other side of it, when we have like our referral form, could be pages and pages.
Just curious, how do the doctors refer?
So the doctors would refer in through System 1 to the link workers, and that would be, or some practices at EMIS, but they would refer through that way. If it's a reception member of staff that is introducing in, they would do that through the same way.
So because we use System 1, so we wouldn't be able to link in the same way.
It would still be better to go through the GP practice if that's possible, just so that we're kind of asking everybody to do the same thing. We're not giving a priority to some people and not to others, if that makes sense.
Yeah, all right.
Yeah, and from our perspective, because we do sit separate to health, we're not on, or we don't have any access to those systems, and it's incredibly difficult to be able to make some of that stuff work. As I'm sure you found, Kerry, the two organisations don't always find it easy to share information in that respect.
Well, hopefully they're going to be bringing us together soon.
Hopefully so.
Councils and health, social care and health. Fingers crossed.
It's the little things. It's things like licenses and user cards, and they cost a lot of money. They're like gold dust for people to be able to plug in these things. It is always those little practical things, I think, that make life difficult for people. But hopefully, and I suppose from that perspective, Kerry's got the background in social care, but is working in the health side of things. This is kind of groundbreaking for us, isn't it, that we do these presentations jointly, and we try and show both sides of it and how we can just work better together, because at the end of the day it's a person that needs something, and that's what's important, isn't it? So we try and have a bit of a no wrong door policy, don't we, Kerry?
We do indeed. We do indeed. Because obviously the local area coordination role has that longevity.
Yeah.
So if
and likewise, we're not everywhere. We don't have the coverage in the same way that the link workers do. Deanne, you've had your hand patiently.
That's all right. I just there was a couple of things really. I just want to say a huge thank you on behalf of the AHPs across Leicestershire and Rutland. My name's Deanne Rennie. I'm Associate Director for AHPs and Quality in LPT, and it's been a really interesting session, and I know there's a lot of people choosing to listen back to recordings because of the significant pressures currently on services at the moment. What we're doing is making sure that these sessions are available to teams to watch either together as teams, or people can watch them individually. And Kartik, who's our comms lead for this particular week, is doing a fantastic job of making sure everything's available for anybody who wants to listen back. And I think there may be other teams that would want to take you up on the offer of inviting you in to talk to teams as well. I think it's really important that we get the messages out as far and wide, because the services you offer is fantastic, and I know for many services people really want to know more about those. So thank you so much for coming to talk to us. And if we can have a copy of your presentation and also the leaflets or any materials you'd like us to share, we can add those onto our website, the web page as well, for people to access. So thank you very much.
No, it's a pleasure. Thank you for having us. And yeah, any further conversations, because I think if COVID's shown us anything, it is that power of working together and the difference that communities can make, isn't it? And so, yeah, thank you for having us.
Thank you very much.
I think Sarah's had some IT issues, so I think she's dropped out and trying to type something in.
Oh, bless her. Oh, well, we'll say a big thank you on behalf of Sarah, and we'll look forward to seeing the resources.
Yeah, and I'm happy for Sarah to share my email address, and I'm sure Anna will too. So if there are any further questions, drop us an email, and we can always come back that way.
And thanks very much.
Thank you very much.
Thank you.
Thank
Nice
you.
to see you.
Nice seeing you. Bye.